Hello, my name is Jaspreet and I'm a second year master's student. So in today's class lecture, we will discuss diabetic care. In your clinical placement, you will be taking care of a diabetic patient. So I think it's important to understand how to do a diabetic care. So this is a skill I hope you will be able to practice your clinical placement and will be able to master it by the end of the semester. So today we will discuss when and how to monitor the glucose levels. We will also talk about different types of insulin, how much to give based on the patient's glucose reading, and how to prepare and administer insulin. Last but not least, we will talk about nursing care of a diabetic patients, including the foot care. So as a learning outcome, by the end of today's lecture, we should be able to analyze how the concept of a glucose regulation applies to the diabetic patients in the clinical practice. First is the glycemic management. What is a glycemic management? It usually refers to identifying and treating a hyperglycemia or hypoglycemia in patients with either pre-existing diabetes or a new diagnosis of a diabetes. As a nurse, you are required to support patients to meet the recommended blood glucose targets while they are staying in a hospital. Why is it important? Because maintaining blood glucose target is necessary to ensure patient safety, and it mitigates the immediate risks associated with the hypoglycemia. Optimizing glycemic management has been shown to decrease the risks associated with hyperglycemia, including delayed wound healing, hospital-acquired infections, mortality, increased length of a hospital stay, and other related complications. Next is the different types of testing methods are available. Before starting any diabetic management, it is important to know the patient's blood glucose level, so which can be done by using different methods. First is the blood work and testing hemoglobin A1C levels. It is a standard blood test used to diagnose type 1 and a type 2 diabetes and monitor how well blood glucose levels are managed. And hemoglobin A1C test result reflects someone's average blood sugar level for the past 2 to 3 months. Second is the fasting glucose. So it is also a blood testing method where a blood sample will be taken after overnight fasting or approximate after 12 hours. It is important to remember that both the hemoglobin A1C and fasting glucose tests are performed in the laboratory. The second one is a point of care blood glucose monitoring. It refers to the devices used for the daily glucose monitoring. They come in a different shapes and sizes. The one we will learn about and use in the hospital is called AccuCheck. So a drop of blood will be put on a strip while strip is inserted in the machine. And machine usually provides blood glucose readings instantly. Next is the ketone testing. It can be done both at the point of care and in the lab. So it is done by checking either urine or the blood. In diabetic patients, the body burns fat in the absence of insulin, and ketones are released as a waste product, indicating a poor glycemic management. This test could be completed in the lab or by patients themselves using point-of-care devices. The point-of-care devices for ketone testing can be done either using a machine, which is usually quite similar to the one used for blood glucose, except that urine will be used instead of a blood on the strip this time. Or simply use simple strips that is called a dipstick method, in which the stick is dipped in the urine and color changes depending on the amount of the ketones present in the urine. Next, you can see this blood glucose monitoring. It is a point of care testing. This is an EcoCheck, and this is the one you will be using in the hospital. So you will be performing it at the bedside. But before performing this skill, you need to be certified. So go on an e-class site under Nursing 225 course, and under the week 6 material, there's a video you need to watch, and then you have to attempt a quiz to get the certification. So more information about the certification can be found again on the e-class. Just please be aware that without the EcoCheck certification, you will not be able to monitor diabetic patients in the clinical practice. Once you get certified, your clinical instructor will provide you with a glucometer barcode. That way you would be able to use the glucometers in the clinical area. Next is the blood glucose target ranges. So once you check the blood glucose, it is important to know what those numbers means. And is there any intervention required or not? So what are the normal blood sugar levels for the healthy patients? In your Nurse 225 lecture, you probably have heard that 4 to 8 feels good. But the story is usually different when you are in a hospital. There are sick patients, and for the majority of a non-critically ill patients, it's important to remember it is a non-critically ill patient. The random blood glucose should be in the target range of 5 to 10 millimoles per liter, with exceptions. Like, for example, in a critically ill patients, if they're in the ICU, their blood glucose target range might be 6 to 10 millimoles per liter, whereas in a frail and elderly patient's range could be 5 to 12 millimoles per liter. So usually these targets are predetermined by the most responsible health practitioner. There are other ranges for the hyperglycemia and hypoglycemia as well. So that we would discuss later with the signs and symptoms and the management of a hypo and a hyperglycemia. Now let's talk about when and how frequently we need to check the blood sugar. Remember, this is the point of care testing we're talking about, not the lab test. So if the patient is taking insulin or any hypoglycemic medications, the blood sugar has to be checked 4 times a day, usually 30 minutes prior to each meal and at a bedtime. But sometimes patient is on oral hypoglycemic certification, so we check 2 hours after the meal. So for example, if the patient is taking insulin, it's an insulin dependent in the hospitals, the checking time would be at 7:30 in the morning, 11:30, and 16:30, which is usually half an hour before the meal times, and 21:30 at a bedtime. Whereas if the patient is non-insulin dependent, the timing would be 7:30, 1000 hours, 1400, and 1900 hours. It is important to remember that meal times varies in a different hospitals. So do the administer times of the insulin. Remember, 30 minutes before each meal. But sometimes we need to check the blood glucose in a non-diabetic patients as well. For example, if the patient takes a certain medications known to increase blood glucose level, like steroids, we might need to check twice a day or 4 times a day if the hypoglycemia is present. Also, when you suspect a high or a low blood glucose levels, based on the patient's symptom, you will need to check the sugar level at random times as needed. Next, we're going to talk about the ketone testing. So this is a urine test and is called a dipstick test. As mentioned earlier, it can be done at home using the point of care or in a laboratory. This is usually done with a severe hyperglycemia, which is when blood glucose level is greater than 18 millimoles per liter, to rule out the presence of ketones in the urine. Urine is collected in a container and the strip is dipped in the urine. You could see this strip with the different colors on it. So the strip will change the color depending on the presence of the ketones. Ketones are produced when the body burns fat for energy or fuel. They're produced when you lose weight or do not have enough insulin to help your body. It uses sugar for energy. Without enough insulin, glucose builds up in your body and cannot be taken by the cells. Since the body is unable to use glucose for energy, it starts to break down fat instead. When this occurs, ketones form in the blood and spill into the urine. These ketones presence indicates the risk of a diabetic ketoacidosis. It's also called DKA in the type 1 patients. Next, we have talked about diabetes. Now we'll talk about the insulin. What is an insulin? It is a hormone produced by the beta cells in the pancreas. As you already know, insulin controls the amount of glucose in the bloodstream at any given moment. But when a person has diabetes, the pancreas is either not producing insulin at all, or not enough insulin, or defective insulin. The problem may also be at the cellular level, when they become resistant to insulin. So person either need to take an insulin or oral hypoglycemics to help with the uptake of a glucose into the body cells. Let's discuss the different types of insulin. So based on the onset period, there are different types of insulins. Rapid acting, short acting, intermediate acting, long acting, and a mixed. Mixed is usually either you mixed rapid acting, short acting with intermediate, or rapid acting, short acting with the long acting insulins. Now we will talk about each insulins separately. First is the rapid acting. It usually starts working very fast within the 10 to 15 minutes of the administration and peak at 1 to 1.5 hour, and effect usually lasts up to 3 to 5 hours. And the common names you will encounter in the clinical area are NovoRapid, insulin glucine, and a Humalog. Whereas the short-acting start working within the 30 minutes of administration and peaks at like 2 to 3 hours, and effect may last up to 6.5 hours. And the common names are Humulin R and Novolin Toronto. Next is the intermediate insulin. So, it is important to remember while giving rapid acting or short acting, only give insulin if your patient is having a meal. If the patient wants to eat later or is NPO, these insulins should not be given. Otherwise, patient might experience hypoglycemia due to the rapid onset. So intermediate acting starts working after 1 to 3 hours of administration, which peaks at 5 to 8 hours and effect lasts up to 8 hours. The common names of intermediate insulins are Humulin N and NPH. Please do not confuse the Humulin R with Humulin N, as one is a short acting and the other one is the intermediate acting. Next is the long acting. Insulins like Levemir and Lantus are long acting, and onset time is approximately within 90 minutes of administration and may last up to 24 hours. Long-acting insulins do not have a peak time. Very important practice tip, do not hold long-acting insulin even if a patient is NPO. It is different than a short and rapid acting. We hold when patient is NPO, but for long-acting insulins, we do not hold insulin if the patient is NPO unless specified by the doctor. When someone is NPO, there's no intake of any nutrients, so no carbohydrates either. However, as the body cells continuously needs glucose for energy, When there are no outside source of a glucose, the body compensates by breaking down fats and proteins to convert those into glucose. Therefore, a certain amount of a glucose is always present in the bloodstream, requiring insulin to take it into the cells. So a patient with a type 1 diabetes cannot produce insulin, but the body always needs basal insulin. So even if NPO, failure to give such patients insulin may lead to DKA, what's diabetic ketoacidosis. Next is the basal bolus insulin protocol. So in hospitals, it is a method of ordering insulin that mimics the physiological secretion of insulin to help achieve the targeted blood glucose level. This includes basal insulin, which is usually intermediate and or long-acting insulin. Then bolus insulin and correction dose generally are rapid or the short-acting insulins. So please stop this presentation here and go and watch the BBIT video that is posted under the week 6 material in your e-class. So now that you have watched the BBIT video, let's discuss when to administer the insulin. Now we know the blood glucose levels and know different types of insulin. Now it is important to know when to administer and what is the frequency. Usually frequency is ordered by the the physicians will order the frequency of the insulin. But it is important to remember that insulin should be administered within half an hour of the blood glucose testing. So the blood glucose testing and insulin administration are timed together. As mentioned earlier, do not administer the bolus or correction dose if the patient is NPO or not eating more than, or no more than 30 minutes before the meals. So if your patient is not eating at the moment, want to eat later, but it has been more than 30 minutes that you have checked the blood sugar, you cannot administer insulin based on that previous reading. You have to recheck the blood glucose level and then administer based on those readings. It could be similar, or you might find there's a slight difference in that. So throughout the lecture, we have used two terms, hyperglycemia and hypoglycemia. I want you to pause the video and think about the symptoms of a hypoglycemia and a hyperglycemia and write it down. What is hyperglycemia? Whenever the blood sugar is greater than 10.1 millimoles per liter, it is considered hyperglycemia. So, but there are three categories. If the blood sugar is between 10.1 to 14.0 millimole per liter, it is called mild out of range or mild hyperglycemia. Whereas if it is between 14.1 to 18 millimoles per liter, it is called moderate hyperglycemia. Whereas if it's greater than 18 millimoles of liter, it is called severe hyperglycemia. So the symptoms include like thirst, fatigue, dizziness, tiredness, polyuria, nausea, vomiting, blurred vision, lethargy, sweet-smelling breath, and a hyperventilation. So what would you do if your patient's blood glucose level is greater than 18 millimoles per liter? Most hospitals have a standardized hyperglycemia protocols, and you can follow that. Like provide insulin or other anti-hyperglycemic medications as ordered and inform your buddy nurse. Review anti-hyperglycemic medication administrations, example, when regular insulin dosing schedule is, the timing of the last administration, held or missed insulin, or anti-hyperglycemic medications. Also review the last carbohydrate administration, what do they eat last, or what intravenous fluid they received. Contact the most responsible health practitioner for the further orders. The most responsible health practitioner may consider physical or lab assessment to rule out the DKA, that is diabetic ketoacidosis, in the patients with a type 1 diabetes. Next is hypoglycemia. So the step one is this in this hypoglycemia glycemia is the early recognition. So hypoglycemia is considered when blood glucose levels is less than 4 millimoles per liter. Patient may or may not exhibit symptoms, but the early symptoms include headache, mood change, irritability. You have probably heard about a hangry, that is hungry and an angry. Tremors, tiredness, tachycardia, excessive hunger, diaphoresis, pallor, paresthesia, or inability to concentrate. And there are advanced symptoms as well, which may include all or some of the early symptoms, along with being unable to recognize and treat hypoglycemia by themselves, disorientation, altered level of a conscious, which includes unconscious state, and a seizure. So please watch a video on treating hypoglycemia as hyperlinked in that presentation. You can also find that on an e-class under the AHS Glycemia Management Policy. Click that link and scroll all the way down to the bottom of the management policy for adults. Over there, you will find the video. In the last slides, we discussed blood glucose testing, types of insulin, management of hypo and hyperglycemia. Now we will discuss the preparation and administration of the insulin. So we have already discussed a type of insulin, but we will go over how you can mix two insulins, how to care for the vials, and the site of administration. Can you quickly think which layer you will administer the insulin? I hope you remember this from your parenteral medication administration lecture in the lab. We will administer in a subcutaneous layer, but in a different body parts like the abdomen, but 5 centimeters away from the navel, back of the upper arms, thighs, upper back, and the lower back. So insulin is usually absorbed more slowly from the sides, like thighs. So this is important to remember when you administer rapid or the short-acting insulin, that where insulin is absorbed slowly or if it's a rapid absorbing site. There are some key consideration which you guys need to remember when administering insulin. First of all, avoid injecting in the same spot. Rotate the location of the injection, and at each site, slightly change the injection spot each time you inject insulin. Excuse me. Every time using the same site can form bumps or pits in the skin, for example. Injecting insulin in the upper, one time you're injecting insulin in the upper arm, next time you can use upper thigh, and next time maybe in abdomen. Next is the absorption rate. As I talked in the previous slide, that absorption rate do vary on based on the site of administration. For example, insulin absorbs slowly if injected in the thigh, so you have to remember when administering that what is the absorption rate and what type of insulin you are administering. Next is the timing of injection. It is important to avoid the fluctuations in the blood glucose level. For example, administer rapid acting just before the meals and short acting 30 minutes before the meal. If you remember the onset of the medication, you could see the rapid acting starts working within 15 minutes. So it is critical to inject it right before the meal. And whereas the onset period of the short acting is at 30 minutes, so you just kind of like administer it 30 minutes before the meal. So insulin administration systems, there are different systems available, but a most common one in the hospital nowadays is this injection pen. You can see the different parts of the insulin pen here. So at the top, there is a little screw and the rubber seal. You can screw the disposable needle. Then you can see this cartridge holder, which holds the medication. Then this is the label that would tell you the dose and expiry date and the name of the medication. Then there is a little window, square window. It is called a dose window and there's a small triangle that is a dose indicator. And there is a screw like a dose knob that will be used to, it is like a dial that you can turn the dial to select the ordered number of insulin units. If you unsure how to use the insulin pens, always check with your clinical instructor at the clinical site. So second is the second administration system is a needleless injection system. So this in this the insulin is administered through the fine stream, and it easily penetrates through the skin. And subsequently the insulin flows the path of the least resistance, spreading evenly in the subcutaneous layer. The third system is subcutaneous injection devices, which may include insulin pumps, and it is not in our scope of practice to manage those pumps. It is generally pharmacist, diabetes nurse, or the physician who manage these pumps. Next is how to administer insulin with a pump. First of all, you have to check the blood glucose level and check the physician order and gather the supplies like insulin pen, disposable needle, and an alcohol swab. Check the insulin pen to make sure it is the right kind of insulin and there are no clumps or the particles in the medication. Also make sure the insulin is not being used past its expiration date. Now remove the pen cap and clean the tip with the alcohol swab and attach the needle. Do a safety test by rotating the dial to 2 units and watching for the drop. Turn the dial to the ordered dose and inject at 90 degrees. Keep the needle in for approximately 10 seconds to administer the total dose of medication. Dispose of the needle safely and return the pen to the medroom after disinfecting. Now is mixing different types of insulin in one syringe. So sometimes we mix 2 types of insulins together to avoid the need to give more than one injection. Like you need to give a short-acting and a long-acting. Before mixing, it is important to check if both insulins are compatible. You can check the parental monograph or consult the pharmacist for the compatibility of the medication. So similar to the technique you learned with mixing parental medication in the same syringe, it is very similar, but there is a specific order to that. First of all, you are going to wipe the rubber lids of both insulin bottles with an alcohol wipe. Remove the plastic cap that covers the needle on your insulin syringe. Do not touch the needle. Pull the plunger back on your insulin syringe and draw air into the syringe equal to the number of units of cloudy insulin to be given. Push the plunger of the syringe to force the air into the cloudy insulin bottle. It is important that you to remember that cloudy insulin is usually a long-acting insulin. Now, this equalizes the pressure in the bottle when you later remove the dose of insulin. Remove the needle from the bottle and pull the plunger of the syringe back and draw air into the syringe equal to the number of a clear insulin to be given. Now push the plunger to force the air into the bottle. Leave the needle in place. You will draw the clear insulin into the syringe first. It is important to follow the order, which is clear to cloudy. Turn the bottle and syringe upside down. Position the tip of the needle so that it's below the surface of the insulin in the bottle. Pull back the plunger to fill the syringe with slightly more than the correct number of the units of a clear insulin to be given. Tap the barrel of the syringe so that trapped air bubbles move into the needle area. Push the air bubbles back into the bottle. Important, make sure that you have the correct number of units of insulin in your syringe. Now remove the needle from the clear insulin bottle and insert into the cloudy insulin bottle. Remember, do not push the plunger because that would force clear insulin into the cloudy, and that will alter the action of your other doses from that bottle as well. Turn the bottle same way upside down and position the tip of the needle so that it is below the surface of the insulin in the bottle. Slowly pull back the plunger of the syringe to fill the syringe with the correct number of units of the cloudy insulin to be given. This will prevent air bubbles entering the skin and remove the needle from the bottle. You should now have the total number of units for a clear and a cloudy insulin in your syringe. For example, if you need to give 10 units of a clear and 15 units of a cloudy, you should have 25 units in the syringe. Now you're ready to give the shot. So as I mentioned earlier, one thing you have to keep in mind that it is usually clear to cloudy, means short acting to the long acting. Next is tissue integrity and asepsis in the diabetic patients or the diabetic foot care. Diabetes can be kind of a significant impact on the tissue integrity due to the nerve damage, which is also known as a diabetic peripheral neuropathy, and a poor blood flow or circulation to the legs or feet, which is known as peripheral arterial disease. As a result, people with diabetes are less likely to feel a foot injury, such as a blister or a cut. Diabetes can make these injuries more difficult to heal. Unnoticed and untreated, even minor foot injuries can quickly become infected, potentially leading to the severe complications. So, as a nurse, what are your responsibilities while caring for the patients with the diabetes? Thorough assessment when checking the feet and between your toes to ensure no cuts, cracks, ingrown toenails, or blisters are present. During assessment, if you found any ingrown toenails, warts, or slivers, cuts, blisters, inform the buddy nurse or the most responsible health practitioner and resolve the issue. Do not try to treat yourself. Instruct the patient or assist the patient in regular cleaning of the feet, especially between the toes, and apply moisture. But do not apply moisturizer between the toes, as constant moisture can cause skin breakdown and foot fungus. Instruct the patient to wear a well-fitting and sportive shoes, and also to trim the toenails straight across to wide hanging nails. In the hospital, you're not allowed to cut nails or provide nail cutter to the diabetic patients. Please remember that. Next is the offloading. How to take a pressure off if patients end up with a foot ulcer. Diabetic foot ulcer can lead to infection and amputation if untreated. So diabetic offloading devices are used to treat or prevent foot ulcers. Their purpose is to redistribute the pressure on a plantar surfaces, thereby reducing the risk of a foot ulcer and infection. Common offloading modalities include removable cast, walkers, and total contact casting. For example, total contact casting may use a fiberglass or a plaster to support lower legs by redistributing pressure from the ulcer to the entire foot. Redistributing pressure helps to manage swelling and reduce the risk of infection. Next is the charcot foot. Charcot foot is a rare but severe complication that can affect persons with a peripheral neuropathy, as discussed earlier. It is a nerve damage due to the diabetes, especially it developed in a person who has a peripheral neuropathy. This is a condition in which the nerves in the lower legs and feet have been damaged. The damage causes a loss of sensation in the feet. Charcot affects the bones, joints, and soft tissue of the foot or the ankle. The bones become weak and can break, and the joints in the foot or ankle can dislocate. If not caught in its earliest stage, the joints in the foot collapse and the foot eventually becomes deformed. A deformed foot can cause pressure sores to develop in the foot or ankle. An open wound with foot deformity can lead to an infection and even amputation. In the early stages, the foot is red, feels warm to the touch, and has significant swelling of the extremity. So it is important to identify the early stages of the charcot foot before it gets deformed. So this is the end of my presentation. I have attached the knowledge application worksheet for you guys. Once you completed it, please check the answer video. Please complete the scenarios as you might encounter similar scenarios in your clinical setting. Also, do not forget to complete your EquiCheck certification. As you know, you will not be able to take care of the diabetic patients if you have not completed your EquiCheck certification. And please do your weekly knowledge checks. Thank you. Have a nice day.